All right.
Here we
It
go.
says live. It says live.
There we go.
Jay.
And Monica.
And we are very, very excited to be joined today with Nelson Vergel, who is
Woo!
the author of Testosterone, A Man's Guide, and pretty much an internet TRT celebrity with
He's
his
a
websites,
superstar.
excelmail.com, and then his new company, which is discountedlabs.com. We're going to talk about all those things in this Hangout. But first, I'm going to pass it over to Scott so he can talk to the people that are watching right now on the side.
Yeah, no, thanks for having me here. I'm obviously moderating, Scott with Viral Marketing, and great to be here with you guys. Great to be here. Nice meeting you, Nelson. As you come on, please notice there's a Q&A box in the upper right corner. Click on the little squares, and there's a Q&A application. It'll open it up. You can ask questions while we're live during the Hangout, and I'll come back and mention that again here in about 10 minutes once we get more people on live, okay?
Okay, awesome. So I'm going to just jump right in. For the folks that are watching now or will be watching, Dr. Brett Osborn will likely call up at some point variously within the Hangout. But a lot of this Hangout today is really going to be geared towards talking to Nelson and talking about the topics that we've already discussed, which is what's the latest and greatest with TRT, his new company, discountedlabs.com, and why that's so important. And then at the end, we'll talk about the next frontier, where TRT is going. So let me just introduce Nelson real quick. First off, from my personal standpoint, Nelson is an amazing, amazing person. He's a true pioneer in the world of TRT. He and Michael Mooney actually wrote a book in the 90s, and it was actually, the book was titled, Nelson, correct me if I'm wrong, but it was Built to Survive.
Yeah.
And it was a book about men who had contracted HIV and were basically in a situation where modern medicine was not helping them. And Nelson and Michael embraced using testosterone and other performance-enhancing medications to stem the tide with the wasting disease of HIV. And I read that book when I was in my 20s, and I honestly was completely fascinated by the subject matter. And I thought that the book was very, very well written, and it was just an expose on things that most people considered taboo at the time. So we're with a guy who's a true pioneer when it comes to testosterone and performance enhancement and helping people, in the context of health and longevity in the world. And so I'm obviously, Monica and I are very, very honored and thrilled to have him here today with us.
Thank you, guys.
Yeah, so Nelson, let's talk a little bit about that. Let's talk about where we are today versus where we were when you really, were the pioneer and like kind of the upstart young guy, back 20 years ago.
Well, first of all, let me thank you, Monica and Jay, and for having me. 'Cause I've never done one of these before, so I'm very excited.
Yay!
And thanks for the kind words. I was just trying to survive back in the days in the 90s. I was wasting with HIV. I've been HIV positive for 33 years.
That's awesome.
And also cancer survivor too. It's like I've had a few rough spots, but
awesome.
I'm living proof that good nutrition, hormonal balance, some supplementation. Obviously, in my world, we have antiretroviral drugs too that obviously help us a lot. So
sure.
I'm living proof that with HIV or cancer, you can actually survive and thrive. I'm 56 years old, so I also have that disease.
How old are you? Wait, no, wait. Say that one more time. How old?
I'm 56. 56.
I
have no hair though. I mean, I lost all my hair. But anyway, so it's my life has been. I'm a chemical engineer. I never really planned to do this. To work in hormones, and I wanted to be a doctor when I was a kid, but long story. But it wasn't until I got sick with wasting syndrome that I said, screw it, I'm going to die or do something. So I devoted myself to this field. And actually, I left my job with Shell Oil and started doing this. I became obsessed. And that is basically leading me to where we are now, basically, 30 years later, talking about men's health and testosterone replacement for all men. I basically branched out like 7 years ago from the HIV world because, we are doing better in that world, and said, we've learned so much in this in this horrible disease that it's time now to spread it and give it to everybody. So that's my goal, and that's why I wrote the book Testosterone: A Man's Guide over 5 years ago, and now have Excel Mail and Discounted Labs. So it's all a transition from me starting as a desperate man trying to survive to creating a program called the Power Program with hormones and supplementation and all that, to now moving on and actually spreading the gospel of health to everybody, whether or not you have a disease or not. So I'm very excited. I'm very happy. Very excited to get to work with you guys, because you're pioneers yourselves in the world of men's and women's health. So thanks a lot for having me here. So
you're quite welcome, and we're, like I said, we're honored and thrilled to have you here. Let's talk a little bit about your book. Well, let me just say, I read your book a long time ago. I think it came out in 2011. Is that correct?
Yeah.
So it was 2011 was the first version, and of course I read it myself right away, and then I think you had a second version come out after that or whatever. But I mean, I think I've read your book to and fro. What would you say? From your book, and by the way, everybody, his book is amazing. Again, it's Testosterone is a Man's Guide.
But it's not as cool as yours. Not as cool as the one that's coming up.
Let's just be honest. I stole a lot of stuff in here. I mean, I didn't plagiarize it or anything, but a lot of his ideas I used to base this on.
And you made him better. With a lot of graphics.
Like attracts like.
I appreciate that. But
my book is great, but it's not as fun reading as yours. I tell you that. Yours is coming up.
I really appreciate that. I really appreciate that. Let me just ask you then, regarding, because I want to jump into your company here in a second. We got plenty of time, and we're going to have questions and answers. But what would you say about your book that makes it a must-read for any guy who's considering, well, not just considering TRT, but already on TRT?
Well, it's a book written by a patient.
Right.
A book written by somebody that has used every single option described in the book.
Right.
I'm not an MD, never have. I don't play one on TV either. So it is a book that comes from the patient side of point of view. So a lot of the books have been written by doctors, and they're great. I mean, I tell you, I've learned a lot from Shippen and from other doctors too. But I was the first one to come up with a good patient-driven book, and it was basically my experiences over 25 years of using testosterone. I've been on testosterone since 94,
awesome.
93, almost 94. And obviously, and I've tried every single option, even the latest ones, which is a nasal gel. We'll talk about it, by the way. New products are coming through. So yeah, but my book is done great. People love it, and but it, as I said, yours is exciting me because your book is graphic, it's fun, and it shows actual information in a tabulated format. I was never good at doing that kind of formatting in my book. So I'm looking forward to a new, easier to digest format, because mine is a little thick in content and in formatting. So
right. No, I mean your book is the Bible. I mean, I've told many men about that, about your book, and I know I recommended many men, and you're right. I definitely did not. My book is a little different from your book from a standpoint of I tried to dumb it down as much as I can, because I think we both know it's an esoteric topic at best, and you lose the engagement of your audience when you start really going into deep molecular biology and endocrinology and stuff like that. So I have it segmented where there are parts of that for the guys that really want to understand it, like dorks like you and me. And then for the general guy who wants the meat and potatoes, okay, how do I get a doctor? How do I go down the TRT road? I think it does a good job quantifying that. But your book does too. And like I said, I really did base my book a lot off of what was in your book. I just tried to take the best of your book, the best of some of the other books that are out there, and then just make it in a really, really easy to digest format for people. And as you've said and other people have read it, I think it did come off that way. So hopefully it'll be in the hands of everybody within a month or so, literally, but within a month, and we'll go from there. So real quick then, before we jump into discountedlabs.com, Scott, did you want to say anything real quick?
Yeah, so real quick, I know there's a lot of viewers watching this live. Guys, in the upper right corner, you'll see a little, there's some little squares, little boxes. Click on there. You can hit the Q&A application. It'll open up on the right side of your screen. Ask questions. We'll get them answered live while we're on the call here. So please feel free to ask us questions, and we'll get them answered now or either at the end.
Sure. So okay. So real quick. I want to just ask you some general questions, Nelson, and then I want you just to kind of just pontificate a little bit about the general market space right now as it is with TRT. Let me just ask you a question. This kind of comes from my book. It comes from a lot of the articles that are happening right now. But do you feel that there is a war on men right now in the current day and age?
I think there's a war on men's health research. I don't think there's some war of men. I mean, this is a male-dominated word. So,
Sure.
but definitely, I think we're not as advanced in men's health research as we are in women's health, even though
Right.
people complain that women are not included in clinical studies. So I do, but it's getting better. It's getting better. Every
Sure.
conference I've gone to, I see a more open mind approach. I just came from a urology conference. I was blown away by how
Right.
they were talking about HCG, about testosterone, clomiphene, you name it, long-acting testosterone. They even had a bodybuilder speak. So
Right.
I was very surprised. So it is moving, and I think it's our work, the work that you do, the work that we are all activists. We're advocates. That's what we do, and we get the word out and try to do it so that people can understand it before going to see the doctor and having an intelligent discussion. So I think all of us, like I said, I come from a world where we had to fight for our lives in HIV, and we were activists. We're getting out on the streets. We get online all the time, educating people. We're actually right now doing that in men's health. And I think we're going to move faster than ever. And it's already happening with the approval of several products and more companies investing in products related to men's health. So I'm actually very optimistic.
That's actually a really good way, the way you phrase it, more of a war on men's health research. I agree with you. So let me just move that question to, the next logical question. Obviously in the media recently, there's been a bunch of stink made of Bruce Jenner becoming a woman and all the nonsense that's around it. And obviously my opinion, I'm sure you share it with me, is let a person live their life. They can do whatever the hell they want, right? But the reality is that, a lot of people, including myself, because I wrote a blog about it, have taken not the argument, but the idea that, if he can do that, then why is it so difficult for a man who has low symptoms of low testosterone at 40, 50, 55, whatever, in North America? Why is it such a taboo, demonized, or stigmatized moment for that man to think that he has to go and try to get his hormones optimized?
I get your point.
Yeah.
Well, let's talk about access to care and access to treatment,
Right.
and that's where the problem is. I mean, she went to a specialist in Los Angeles. She has money.
Right.
Obviously, a lot of the stuff is not covered by insurance, so a celebrity like her probably has access to better things than most of us.
Right.
So I'm not saying that male to female transsexuals don't have access to, but it is hard when you don't have the financial means. So let's move that. Let's put that aside. And I'm obviously I'm a gay man, pro anybody doing what's right for them as long as nobody else gets hurt. So I'm a libertarian when it comes to that.
Sure.
And obviously, for obvious reasons, I'm biased. But anyways, when it comes to men, I'm seeing a lot of problems. I see the shame that comes from actually discussing sexual function related, or fatigue related issues with your friends in the male world. And I see also difficulty for men to access good physicians that are educated and also are open-minded to try things that may be what we consider off-label, and yet we have good data on. So it is basically very hard for a regular guy that is not really reading a lot of information online to find a doctor that is progressive, not only about testosterone, hormones, thyroid, prostate health, et cetera, et cetera. And that's why I see the number one emails. I get emails every day. It's
Right.
that. It's Nelson, I read your book. Where can I find a doctor that knows what they're doing? So that is, for me, the biggest barrier. A lot of insurance companies obviously do not want to pay for certain, testosterone replacement options, or they may have imposed limits on blood testing. So unless you have some cash, so I see a lot of barriers, what we call barriers to access,
Right.
for somebody that has low testosterone, is fatigued, is not doing well at work, is not doing well at their relationship, may have sexual dysfunction that brings in some shame, and does not have a support system. So hopefully our work, yours, mine, online, can serve as a support system, and also to direct them to good sources of trusted physicians and physicians networks that are up to speed on the latest data and the latest studies on men's health.
Awesome, and with that, we'll segue with a good physician that we like to think does a pretty good job.
Fabulous, great.
Dr. Brett Osborn has joined the party. What's up, Brett? How are you, buddy?
Oh, in the house.
Hey guys, how are you?
Hello, Dr. Osborn.
We're good.
How are you, Nelson?
Dr. Osborn.
Say hi to Nelson. I don't think you guys have ever formally met yet, correct?
Now we are.
Yes, you are.
No, we are.
You guys have broken bread. So are you? I assume I see your outfit. You're on call right now, right?
I am.
Awesome, awesome. Well, we appreciate you taking the time to
thanks,
join.
Dr.
And, as you always do, you are a man of
course.
talent.
Thanks for inviting.
Coming up. So real quick, we're just talking a little bit about Nelson and his background as a TRT, internet celebrity / entrepreneur guy that's really done a lot of stuff for TRT, and talked a little bit about his book. And then he had just very eloquently, I thought, answered the issue, the biggest issue in the marketplace today. So just jump in real quick, Brett. Your thoughts on why are doctors so poorly trained in administering TRT?
No, I don't think it's a matter of being poorly trained. I think that
Poorly informed, maybe, is a better word.
The problem is that there's a lot of sort of inertia in the in the medical community as far as their ability to accept data when there are a lot of conflicting studies at this point, even though we know that the vast majority of these studies that have come out, and there are few of them that have sort of negative connotations. Everybody seems to hang their hat, on these negative studies, and there's always much more sort of media and publicity on negativity, about negative results, or about bad outcomes, supposed bad outcomes, than there is media on sort of a positive effects of these medications. I can tell you, and Nelson can tell you, and you can obviously have your own experiences, Jay. I've had far more problems, neurosurgically speaking, than I have ever experienced, in the context of hormone replacement. So we know for a fact that testosterone does wonders for people. It literally is a life-changing drug, and I can tell you that there aren't many of them out there, that have similar efficacy and similar effects on sort of the total person, the global effects that testosterone replacement does, and estrogen and progesterone replacement in female plus or minus testosterone does as well. Because what you're really doing is you're just reestablishing sort of the hormonal environment or milieu of sort of returning them to a youthful hormonal profile. And by virtue of that, there are a zillion effects, if you will, that really render this person to a great degree young again. Now, we can't necessarily reverse the aging process with testosterone, but we certainly can slow it down. And again, there are no other medications that I know that will allow you to sort of reestablish, if you will, your youth. And that's really what an optimal hormonal profile does. So the medical community is very, very slow to sort of adopt this line of thinking, again, because there's a lot of recent data, which is spurious data in my opinion, and poorly generated data, that says that testosterone has very, very bad side effects. But anybody who's used it, okay, myself included, can tell you that that's simply not the case. Now, that doesn't necessarily mean that everybody willy-nilly should be put on testosterone, but there are certainly many, many Americans, and we're only treating a small number of them at this point, who would do extremely well, again, globally. And I'm not going to go into all the sort of beneficial effects. I'm sure it's been already stated in the first 15 minutes, who would benefit from these from hormonal replacement. And the medical community, it's not so much that they're not being educated. I think that they're being educated, or I think that they've chosen to pay attention to the wrong data. They should really, every doctor should be, it should be mandatory that every doctor goes to some of the anti-aging meetings that we've all been to, and listen and learn. We need to sort of move away from the results of that one study, which was published in 1938 with an N of 1. We seem to all hang our hats on that one study with a single patient.
Right.
And take
prostate.
Right.
Yeah, that's right. And that's right. And instead, take a look at what Morgan Taylor is doing. I'm sure you saw what I just shared on Facebook yesterday.
Yep.
I think it was yesterday or 2 days ago. He came out with a very, very a great sort of rebuttal about the efficacy of testosterone replacement, and the fact that it is extremely safe if administered properly under the care of a properly trained physician. And you know, I will say that the knowledge needed to start writing testosterone, it's not the knowledge that is needed to you know, become a surgeon. You know, you don't need 4 or 5 years of residency in order to be able to understand the physiology of hormonal decline, age-associated or age-related hormonal decline, and to be able to supplement your patients with testosterone for a female, progesterone, estrogen, thyroid, et cetera, et cetera. You don't need to be an endocrinologist, okay, to do this, okay. Although the endocrinology societies would comment to the contrary. But that's simply not the case. This stuff is not very, very hard. It just requires a little bit of attention to detail, a little bit of knowledge, and physicians would soon come to realize that they would be dramatically impacting their patients' lives more so than the majority of any of the treatments that they're offering these patients thus far. Because as you are well aware, hormone decline, age-associated hormone decline, is a risk factor for disease. It's a disease unto itself, and it's also a risk factor for other diseases. Just like hypertension is, just like insulin resistance is, just like type 2 diabetes is, just like obesity. It's you know, having your hormones optimized is equally important, okay, if not more important than you know, exercise itself, because all you're doing when you're exercising is you're actually just bolstering your hormones and restoring your hormones to that of youth. Yet there are other benefits to exercise, but one of the main effects of exercise is the fact that I was just talking to my kids about this today. Is the fact that you are in essence giving yourself testosterone, giving yourself growth hormone, giving yourself anti-inflammatory medications by virtue of the exercise. So that's really what you're doing, and that's why people feel good when they exercise, because they're restoring to some degree their youthful hormonal profile. So it's a shame. I think that the answer to your question is that it is a multifactorial sort of problem that we're having. It's not that there are necessarily bad doctors. It's just that we are very, very set in our ways and stuck, and we like everybody else to hear sort of bad things as opposed to hearing good things. So those are the things that stick out in our mind. Instead of some of us, I guess we're billed as rogue physicians, saying, you know what, maybe there's something to this, when there really is, and everybody just needs to give it a shot. And I can assure you that if they do, if these physicians do get on board, they'll realize very, very quickly how wrong they actually were, and how they were depriving their patients of something that's potentially of tremendous benefit.
Right.
So Nelson, let me jump in there real quick, because a very good segue. You just came from the urology conference in Houston. Basically what Brett's saying is I agree with him. Obviously you and I, deal with so many different patients and men that email us and write to us, as does Brett, saying, oh my God, this is what my doctor, I started with this doc and this is what happened and blah, blah, blah. And it's just it's a comedy of horror. So what do you think, Nelson, from an educational standpoint, where do you think it's going? Obviously you said that you saw amazing stuff at the urology conference, but do you think that that's going to be like at the forefront of the next 5 years of like maybe some sort of mandatory program out there that helps educate docs?
I think urology is more advanced than endocrinology right now when it comes to TRT. I see it. A lot of the guys that email me or contact me with a lot of frustration usually come after a consult with an endocrinologist. And the urologists, at least the ones I know and as I saw in that conference, are opening their minds up more about the benefits of testosterone and the flawed nature of the only three, and there were not studies, there were reviews, chart reviews, that showed that there was a potential or risk of increased cardiovascular risk. I read all the papers, and I have to tell you, they should be, actually, the paper authors should be, there is actually malpractice what they did. They send patients, they get prescribed mostly androgel or testosterone, one of injections, send them home without monitoring them again.
Right.
Never check their or manage their hematocrit, their red blood cell proportion. Never check their estradiol, and so never monitor. Actually, half of them dropped out. They even included, one study included women in the cohort. So it's very sad, like Dr. Osborn was saying, the fact that the media and lawyers, attorneys, focus on those studies so that they can go after the pharmaceutical companies, and there's actually a class action lawsuit that doesn't have a very good chance to go through. I think what's happening too is that, and this is unfortunate, we have, I don't know, last time I counted, we have like 12 or 14 testosterone replacement options, pharmaceutical, FDA approved, and there are probably 5 or 6 in the pipeline. What happens is that a lot of primary care physicians, family practitioners, anybody like Dr. Osborn was saying can prescribe testosterone. Most of them are getting their training from a pharmaceutical rep that walks in into their office, and basically the pharmaceutical reps are not talking about side effect management. Like I said, managing hematocrit, estradiol, the testing frequency, et cetera, et cetera. They're not talking about it, because I know a lot of doctors and they say, well, the androgel rep basically came in. They don't have, a lot of doctors don't have CME credit, classes where they can actually learn the proper management. And like Dr. Osborn was saying, right now the only sources for education for doctors are the anti-aging conferences, or some conferences like the American Urology Association that are happening in New Orleans, which, I was pretty surprised that they had a whole afternoon for testosterone replacement and all these issues surrounding the study. So I think it's probably going to improve. I don't think it's going to improve. The education of doctors is not going to improve from the pharmaceutical side. They really are not interested in I don't know why, in educating when it comes to side effect management. I think, I hope medical schools at Baylor School of Medicine here in Houston, I work with Dr. Lifschultz there a lot and his group, they actually have it in their curriculum now for physicians to take. So it is probably going to be a changing world with the younger physicians that are going through medical school, and the older ones are hopefully going to be picking it up from conferences or publications. I mean, most doctors don't have time to update themselves. So I think there's been some sort of witch hunt in the past 2 years, ever since at least the VA study came out. And a few doctors, the ones that are not very versed in this therapy, are actually afraid of litigation, and they are saying no to a patient that comes in with a 250 testosterone blood level, having all the symptoms. So, but I think the smart doctors that know what's the right thing to do is also a good thing for business to be educated in this area. A lot of doctors are are embracing a comprehensive approach of nutrition, exercise, diet, dietary supplementation, hormonal balance, of all the medications that you need for your primary care. So it's moving. It's just that we have a long way to go. I think maybe 10 to 15% of men that need help are getting the help they need right now.
Yeah, I would say it's less than that, but I agree with you. It is moving. It's like Brett says, there's just tons of inertia. Scott's going to jump in here in a second. We got a ton of questions, it seems like, on the side from people that are watching. But I want to just, before we jump into the questions, Nelson, I want to just plug a little bit about discountedlabs.com, and then I want Brett to comment a little bit about it too. But I mean, I think where this goes is, so if you're a guy and you're watching the show and you're not on TRT and you don't know jack about TRT other than what you've read from me or Nelson or, our blogs or Brett's site or whatever, and you have the symptoms of low testosterone right now, and you maybe are facing inertia or some form of resistance. Let's say you're in the Midwest, you're not in a giant coastal population center, there's not a famous TRT physician near you. Nelson, talk a little bit about your company and like what their options are now from a private standpoint of them being able to go and get their blood work done.
Yeah, I've been working in this field for, as I said, 24, 30 years. And the first thing I've noticed is how expensive blood testing is. I mean, obviously, if you have insurance, you can get some blood tests paid for. They do have a criteria, so it's really basic blood test. Once you go beyond what they consider basic, and basic is really basic, you have to pay out of pocket. Sometimes these guys, I mean, I hear guys are using their insurance, thinking that the insurance is going to pay for blood work, and then 3 months later they get a bill from the insurance company saying, no, we are not paying.
Right.
It's your responsibility. You have to pay, $1,000, $2,000. So that's becoming more and more common, and I was really disturbed by the fact that a few companies online were really, really expensive. And I believe that every man, and this is not, like Dr. Osborn said, this is not too difficult. I mean, anybody that can do a little reading can know that, you keep an eye on your testosterone, blood levels, estradiol, hematocrit. If you are having issues with thyroid, you do a little bit of that thyroid profile. And then, that gives you more tools to have an intelligent discussion with any doctor in your search. So my company is the cheapest, most affordable online. We do not have 2,000 tests. I only have 52, which are the most popular ones. We even have a TRT panel, a pre-TRT panel, meaning for those that are not on testosterone yet and they need to find out if they're hypogonadal, if they're primary or secondary hypogonadism. There's a thyroid panel, there's a metabolic panel. So I hope that easier access to blood testing anywhere in the U.S. except New York and Massachusetts. Those two states have passed legislation to block any outside labs from operating. Can have tools so that they can have an intelligent discussion in their search for a physician. I mean, so a patient that actually comes in and with some knowledge of what their blood work is, it's a lot more educated than somebody that is just guessing. Another thing is that a lot of, and I don't want to really moralize this, but a lot of guys are self-managed, especially in the athletic world, where they're taking some substances and they have no idea what's happening to their bodies, their blood work. And I want to make it easier for them at least to have what we call a risk reduction or a risk management approach to at least know if your hematocrit is high, if there's something wrong with your estradiol or your thyroid or whatever it is, or your creatine, your kidney function or liver function. A lot of those guys that may or may not be abusing substances, at least do it more intelligently. So I think it's the right, everybody's right to have more tools to empower themselves to take better care and better decisions about their health. So hopefully, it's a new company, it's only 3 months old, but the word is spreading, and we're doing a little educational stuff there too, so people are more empowered to read their blood work. And hopefully people will start using us. So. Yeah,
so real quick, so for the guys, and then I'm going to jump into you real quick, Brett, and then Scott, you can ask questions because I know you have a bunch of them. But for the guys that are basically, doing this in gray market format or underground, and they're not using care of a physician, they can't afford it, or they can't have access to a good one or whatever, Nelson's company makes it really simple for you to, inquire about your blood panels, okay, and to figure out exactly what's going on with you. There's absolutely no reason if you're going to embark down a gray market, testosterone therapy solution, or even if you're using other substances like synthetics or anything, that you shouldn't know what's going on with your blood work, okay? So he makes it very, very easy, and it's obviously highly affordable. I just did one. I did a blog. You guys can go to my site. I just wrote a blog about it about 3 weeks ago on my site. But I did it myself, and literally it was so painless. You go online, you order the piece, you pay for with your credit card or PayPal or whatever, and then they email you. You take it to LabCorp or you take it to Quest, whichever's closest to you. You hand him the piece of paper. You don't need a doctor's script. You've already gotten it through his company, and they take your blood, and then literally within 3 to 5 days, you have an email and you have your entire blood work. Now, hopefully, if you're going down these paths and you're already doing it gray market or black market or whatever, you know enough to be able to read your blood panels. But if you don't understand how to read your blood panels, you can always send an email to myself or Nelson, and we can help you and point you in the right direction. But again, I really, really got to give props to Nelson for doing this. There are other companies out there, but everybody should be monitoring their blood health. And listen, if you can't get a blood test, if your doctor blocks you, you're 30, you're 28, you have symptoms of low testosterone, whatever, this is the route that you go, because once you have access to your bloods, then you can have a more intelligent conversation with a doctor, and hopefully you can be, if you qualify or hypergonadal primary or secondary, you can actually get scripted for testosterone.
Thank you, Jay.
You're welcome. Doc, you want to add anything to that?
No, the only thing that I would add is that, Nelson, I think that's very, very commendable what you've done. Not so much from a sort of an entrepreneurial standpoint. I mean, that's all well and good, but I think that sort of at base level, what you're trying to sort of the messages, at least to me, is one of control, which is something that I'm all all about. And you can ask Jay and Monica about this if you don't know about some of the things that I've written about in the past, and that is really the assumption of control of sort of oneself and one's health. So, by virtue of what you've done, you are enabling individuals to assume control of their health, and by virtue of that, seek help wherever that may be, or with whomever, and allow them to sort of control their health destiny, if you will, as opposed to being victimized by the very, very sort of corrupt system that we call erroneously health care, because it's really not. By sort of launching a preemptive strike, on this disease of aging, if you will, or at least the underpinnings of this disease of aging, by virtue of the fact that you have access to sort of the biochemistry, your own biochemistry, because you've provided that for everybody. You're sort of one step ahead of the game, and you should be doing these things, as you pointed out, or as we've pointed out many, many times in the past, at an early date, even before you start developing some of the symptoms of hypogonadism, and that's really sort of the theme of this clinic that I'm going to be opening. We're going to be doing lab assays and things like that, and in addition, we're going to be taking snapshots of people's insides. How? Using ultrasound, taking a look at their carotids, looking at their heart function, their cardiac function with echo, looking at their aortas, looking at their femoral arteries, seeing the velocities, taking the intimal medial thickness, and finding out whether or not these patients have early evidence of aging or age-related disease. And the biochemistry is obviously is part and parcel of that. But all of these things, we're going to be doing some cognitive assessments, but all of these things sort of come together and really allow you to get a snapshot of what your body is doing sort of at the inside, which is really where the disease is. By the time your skin starts changing, et cetera, you're probably already far along in the age-related disease category. So you really want to take a look at the inside, and what you've done, I think, is spectacular, because you've really enabled the individual to, or empowered the individual to, sort of get a jump on it and not be reliant on a doctor who may not be of the belief that a 35-year-old needs to have their biochemistry assayed.
Thank
That's
you.
really commendable.
Well
Absolutely.
said. Well
Thank
said.
you. Appreciate it.
Hey, all right, so I'm going to jump in with some questions here. So, Jay, I want you to answer this one first because this is something we talk about all the time, and I think you can run through this real quick. But Cody asked, if you start TRT, is it a lifetime commitment? Can you stop after several years, and will your body produce testosterone again on its own?
Well, that's a great question. It's multifactorial, and the answers are really are varied. It depends on your age. If you're going to commit, and we write about this in the book. Nelson writes this about in his book. We can both speak very eloquently about this. If you're going to commit to doing TRT, it should be a life goal, because what ends up happening when you start testosterone is your natural production, your endogenous production, eventually is shut down through various hormonal pathways. I'm not going to go into any esoteric discussion of it, but rest assured it's in the book. You can buy Nelson's book. It's also in there. So, to answer the guy's question, if you stay on it for 5 years and then try to go off cold turkey, you're probably going to have issues. Now, that doesn't mean, though, that you can't take other medications, which are also written about in the book, like HCG or potentially Clomid, or even a combination of both, that can actually restore your spermatozoa and also restore your natural testosterone production. However, and Dr. Osborn and I talk about this all the time, as you're aging, 30s, 40s, 50s, your natural testosterone is declining, okay? And it's declining by the day. I think it's actually declining at like almost 1% every couple months after the age of 35, or a year. I can't remember the number of the data. But the reality is it's declining, and it's declining fast. So if you're going to start it, why would you want to come off? So that's my answer.
Nelson, you want to add anything to that?
Yeah, I mean, there may be reasons why somebody starts and then wants to stop eventually.
Sure.
One of them I can think of is somebody who was obese or really heavy and got on testosterone, started exercising. Most of the guys I know that start TRT have a secondary commitment, because they know they're going to inject or they're going to apply the gel, whatever it is. So they know that's one thing extra they're doing. So they start working out better. They start watching their diet. They start taking certain supplements. So they start seeing, for instance, improvements in weight, decreases in fat mass, increases in lean body mass. So sometimes we see a person that is very overweight, low testosterone, all the symptoms, obviously, because obesity tends to lower testosterone anyways. And then they lose a lot of weight. They get in shape, and they may think, hey, maybe I don't need it anymore. Hey, the studies that we've seen on people that have stopped testosterone or androgen use after a few months, sometimes it takes them at least 6 months to return to baseline.
Right.
And baseline, remember, baseline was not normal.
Right.
Testosterone for a reason.
Right.
So I'm not saying that you cannot attain, and like Jay said, there are compounds that you can take probably to accelerate that improvement. But we don't even have studies on those large studies on those what we call PCT combinations. So it is a lifetime commitment. It sounds like prison, lifetime commitment, but it really is. And most guys actually realize that, hey, it is a good lifetime commitment.
Right. Why would you not want to be on it? Exactly.
Some guys, stop because of side effects that are not well managed, or the physician does not know what to do, and they get discouraged. Some guys, actually, 80% of guys on androgel, a study of over 5,000 patients that followed them for 24 months, so that 80% of them stopped androgel within a year.
Right.
And nobody says, well, was it because they didn't feel the benefits, their blood work didn't show benefit, whatever it was. We're seeing that testosterone itself may not be the problem. It may be the lack of management of testosterone replacement. So that's another reason to stop. Another reason some guys may want to stop because they think they're not going to be able to have children.
Right.
And we're finding out more and more with some data coming through with the use of testosterone with combination of HCG that actually preserves sperm quality and count. So, that reason to stop testosterone for that is becoming less and less valid.
Right.
So I can see why, and as I said, anytime you tell somebody that something is a lifetime commitment, they feel they're going to prison. So I think that language itself, we may have to probably say, hey, you're gonna feel so much better that you're not gonna mind being on this stuff for the rest of your life. That's really how we should phrase it. So.
Yeah, that's actually really well said. Brett, I want you to jump in here in 1 second. But yeah, I mean, obviously anybody can do anything they want. If you're going to start testosterone, your mindset should be, well, why am I starting testosterone? Well, I'm starting testosterone because I have a physiological need. My body is now at a suboptimal level, maybe due to age, maybe due to an injury, maybe due to chronic fatigue. I was talking to a U.S. Army Ranger this week, and he also actually works with Dr. Brett. Dr. Brett works with a lot of those guys. And a lot of those guys, literally, their training destroys or suppresses their endocrinological function so much that they literally have low testosterone from that massive endurance and the lifestyle of those guys. So there could be a number of reasons why people need testosterone. But as Nelson said, I guess using that terminology, a lifetime commitment, does freak people out. But believe me, once you start testosterone, and again, we're assuming you're starting testosterone for medical and biological reasons, there's very little reason or want to come off. Again, assuming your side effects, if you have side effects, assuming your care is managed by a competent physician, as Nelson said.
Perfect. All right, I'm going to jump in another question here from Tyler. How long before the effect of TRT, mood-wise, stability, energy, etc., kicks in, and how long before they reach their deepest effect? So once you start a program, he's heard from 4 to 6 weeks or from 3 to 12 months till you hit your optimum testosterone level. I don't know, whether Doc or Nelson, you want to answer that, but what do you guys know as far as the accuracy of when you start a program?
Doc, you want to take it over first?
Go ahead, Nelson.
Yeah, there was actually that's actually a question I get all the time, and I have a review of a paper that I made an analysis of many studies, over 50 studies or 35 studies, I think, on testosterone, and these guys actually went through all the studies and started tabulating the time to maximum benefit. And remember, we are talking about probably 6 variables, 6 of them. Sex drive, which means libido, which means wanting to have sex. It's not erectile function. That's one variable.
Right.
And the next variable is erectile function. It's a separate variable. You can be horny but not have an erection, or you can have an erection but not really feel horny. Okay, so I'm using crude words since we're talking with guys here. I always tell the guys I'm going to talk like a guy.
Well said.
And we have body composition. Fat mass goes down, lean body mass goes up, strength, mood. So we have I forgot how many, maybe 7 or 8 variables. The first one in the study that actually shows benefit within actually 2 to 3 weeks is sexual drive, sex drive. Okay, and it takes a while because every testosterone product, injections, gels, pellets, nasal, now there's a nasal gel, etc., takes a while for it to reach steady state blood levels in your blood. So it takes a while for the body to have more leveled. So sex drive is the first one. Within 2 to 3 weeks, the maximum effect, I think, is 6 months. I don't have the study in front of me. And lean body mass and fat mass changes obviously happen after 8 weeks or so. It takes a while for the body to, especially if you're exercising, that would accelerate the change. Mood tends to be also as fast as sex drive within 2 to 3 weeks. Some guys tell me, Nelson, is week 3 and I still don't feel that great. Some guys it may take them a little longer than that. Mood, sex drive, erectile function, especially in younger guys, tends to also get better within the first month or so. Older guys, especially men that have diabetes or high blood pressure, they're taking medications for other comorbidities, may have more issues with the erectile side of things. And testosterone may help with that, but it has not been 100% proven to be the solution to age-related erectile dysfunction, but there is some improvement there. Mood, as I said, is dramatic improvement. If you're not having an improved mood, I usually tell people, well, your doctor probably needs to check, thyroid function or the other, or sleep quality. Nobody talks about sleep. Without good sleep, there is not good hormones, there is not good anything, not good sex drive, not good erections. Without good body mass, I mean, if you're overweight, if you're smoking, drinking a lot, staying up late at night, there is no testosterone in the world that is going to help you. because
Right.
testosterone can do certain things, but it cannot do miracles when you are actually not engaging in a very healthy lifestyle. So I tell people, if you're considering this, you need to also consider the comprehensive things that you have to do in your life to maximize the benefits of testosterone and to heck, live longer. Because So, anyways, I don't want to be preachy. So, doctor.
No, that was great. And I'm just gonna jump into another question for you, Doc, and I appreciate that, Nelson. So, Doc, Joe asks, how would you test or treat possible side effects such as testicle shrinkage, hair loss, gynecomastia, and others? I'm on treatment myself for 2 years now, and I'm noticing some of these.
Right. So that's a good question. What you do is you treat these things preemptively. So first and foremost, you warn the patients of potential side effects, which are relatively infrequent, as I had said before. The gynecomastia issues, that's due to the testosterone, an excess basically of estrogen, okay, if you will, because the testosterone gets converted to estrogen via a process called aromatization. Bodybuilders are intimately familiar with this. Okay, nobody leaves my office on testosterone. Okay, whether it's compounded cream for individuals that I don't really trust with needles, and they're on high doses of relatively high doses of testosterone relative to things like androgel, which is almost a homeopathic dose of testosterone. And I suspect that that's why there is a significant amount of inefficacy associated with the low dose or low percentage transdermal testosterones like androgel, et cetera, et cetera. So people typically go out, if they're going to use any type of gels or creams or transdermals, on 20% cream. Androgel is about 1.5%, if you will. So I'm using something that's 12 or 13, 14 or 15 times stronger than what is commonly prescribed by physicians, i.e. brand name testosterone, transdermals. Most people end up going out on injectable testosterone, and nobody leaves my office whether they're on transdermals or injectable testosterone without being on some sort of aromatase inhibitor. So the aromatase inhibitor, like what I use is an anastrozole, it's probably the most common, blocks the conversion of testosterone to estradiol so that patients don't end up developing gynecomastia. Which it can potentially be very problematic, okay, because it's something that potentially would require surgery. And that, quite frankly, is something that is wholly preventable if there's very, very aggressive surveillance by the physician. What do I mean by surveillance? Well, as Nelson had alluded to, if you're if you're starting to notice any of these side effects, you're starting to notice gynecomastia, then it mandates immediate, okay, or even before this, okay, immediate assessment of your estradiol levels with, via a lab test, okay. It's very, very simple. Now, we don't wait that long, okay. We don't wait until somebody starts complaining of it. What we want to do is we want to get on top of this, and we want to take a look at everybody's endocrine profiles 6 to 12 weeks after they start testosterone therapy with me, and thereafter 3 to 6 months serially, okay, so that we don't end up with estradiol levels. If we're targeting, if our optimal level is about 20 and it's just rough, we don't want to have people running around with estradiol levels of 60 by virtue of the fact that all their testosterone, or the vast majority of their testosterone that's being injected or applied transdermally, is being converted over. So that's one thing that does not happen. I've written testosterone for hundreds and hundreds and hundreds of patients, okay? And if you're aggressive about the surveillance, okay, and you follow the prescription recommendations, you simply won't develop it. You're much more likely with me to develop hot flashes by virtue of over-aggressive usage of aromatase inhibitors like anastrozole than you are to develop gynecomastia, okay, in my hands. And I don't mind when people call me and they tell me that they're having hot flashes, which is a sign of low estrogen, like a woman that's going through menopause, by virtue of the fact that they're taking a little bit too much anastrozole, aromatase inhibitor. I actually don't mind that phone call. I do mind the phone call when patients calling and complain that they're having nipple sensitivity, because that's the first step to sort of a gynecomastia type of problem. and is the result of elevated estradiol levels or estrogen. As far as the issues with testicular size or low sperm counts, I always advise patients that this is a potential side effect, and that occurs through what's called negative feedback. And I'm not going to go into the pathways, but it has to do with how the brain controls the secretion of hormones, if you will, signaling molecules that control or modulate testosterone release. So if you give yourself exogenous testosterone, then you're going to sort of shut down the normal outflow of these from the brain, and therefore the sperm production is going to go down, and that's called a negative feedback loop. So that's going to happen. Okay, it's not if it's going to happen; it's going to happen. Okay, as soon as you start giving yourself testosterone, your sperm count's going to go down. Okay, and that's okay because we are prescribing testosterone for individuals that are hypogonadal. Okay, a lot of these patients, in my experience, are done having children. Okay, but even the younger ones. So say if somebody comes in and they have classic symptoms of hypogonadism and they're 30 years old, so they're of childbearing age, and they need to be put on supplemental testosterone. Okay, and they want to have children. Well, in my clinic, okay, I typically discourage them. Okay. Even if they sign waivers, et cetera, and say that they're aware of the side effects, I really will discourage them from going on supplemental testosterone. And what I'll do is I will use, in an aggressive manner, beta HCG. So what beta HCG does is it's like the hormone, if you will, that is released from the brain that signals sperm count to go up and also elevates your testosterone levels. Okay, so it stimulates testosterone production and production of sperm. So I'll use HCG and I won't use testosterone. If you use HCG and not testosterone, you use HCG unto itself, it's going to bring your testosterone levels up, and it's also going to bring your sperm count up as well. So that's something that I recommend as first line in younger individuals of childbearing age, okay, so that we don't have this problem with potential infertility in the past. Now, that said, as was alluded to previously, there are tons of bodybuilders, okay, as an example, who use tons and tons of testosterone and still go on, as Jay and I think Nelson had mentioned, and go on sort of rescue therapy, HCG, Clomid, et cetera, and even after all the testosterone abuse, okay, and this is not abuse. This is physiologic dose. These are physiologic doses of testosterone. These people still go on to have children. I have my daughter is a testosterone baby. Okay, so I brought my testosterone down, my injectable testosterone down, and I stayed on my HCG, and we didn't have any problems. Okay, and that's typically what will happen. Now, if there's a concern, okay, and I'm thinking about putting somebody that's of childbearing age on testosterone because their symptoms are so florid, and as Jay had said before, there are individuals, okay, some of these guys from the military are so knocked down and that they literally shut down the areas of the brain, the hypothalamus, the pituitary gland, to some degree, and despite even pushing them with various other sort of modalities I'm not going to talk about to stimulate them, okay, they're still not generating the correct amount of testosterone that allows them to feel good, and they're still coming in with very, very low laboratory levels. Okay, if I'm thinking about putting somebody like that on testosterone, okay, they're going to be put on testosterone, but they're also going to be put on HCG as well. Okay, so if somebody absolutely needs to be on testosterone at a young age, okay, and is thinking about having children, okay, they're going to be put on both, and they're going to get a sperm count, so that I know where they are, okay, and we check their sperm count before, and we check their sperm count at 6 months to make sure that we're not doing any damage, okay, and if we find out that the sperm count is going down, okay, these people may not be making any sperm anyway, okay, and that's part of the problem, okay, but infertility issues, et cetera, but they may not be. But if they are, okay, and they have very, very florid symptoms of hypogonadism, and everything else has been ruled out, and they need to be put on testosterone. They absolutely need to have a sperm count, okay, and we need to follow that sperm count, okay. Hopefully the HCG in particular will prevent them from going down even further, or even raise their sperm count. So that's sort of a long-winded answer to to that question regarding the fertility of the testicular size. Okay, we do see some testicular shrinkage in patients, but it's a very, very low number, okay, of individuals that go on testosterone that will notice testicular shrinkage. I can tell you that from firsthand experience, because I always talk to my patients about these issues, okay, and nobody, okay, really seems to notice or mind, okay. Of course, a lot of the patients also that I have on testosterone also go out on beta HCG, and I can tell you that the people that are older, they don't even care, some of them, okay, so it doesn't really matter.
It means nothing.
They don't care, okay. The hair loss issues, I lost my hair a long time ago, okay, before being on testosterone, okay. That is an issue. I will tell you that that's an issue that's related to DHT, so dihydrotestosterone, which is a metabolite of testosterone. So testosterone gets converted to DHT, and that's intimately associated with high levels of DHT are intimately associated with hair loss. That said, okay, you can put patients on Propecia, okay. I will tell you that of all the years that I've been prescribing testosterone, I have less than half a dozen people who have complained about thinning hair or frank hair loss on testosterone. If they are worried about it, you can always put them on Propecia, okay, and that's perfectly fine. Propecia does to some degree feminize men because the DHT is the sort of the more powerful metabolite of testosterone, and I'm not going to go into that, okay, but just assume that it's the stronger of the two, if you will. So it counters the effects of testosterone to some degree, but you still have the majority of the beneficial effects of testosterone are still there despite Propecia usage. So that's something that I talk to patients about as well. So I think those are the three things that we just that you asked me about.
At the end, hold on, Scott, real quick. At the end of the day, for hair loss, for guys who are concerned about hair loss is male pattern baldness is genetic primarily. Androgens do speed shedding and can speed hair loss, but I mean, again, we write about this in the book. Nelson's, his Excel mail, they have a bunch of articles about stuff that you can take that are shampoos that actually combat it. Propecia, finasteride is, there's people have side effects with that, as Doc alluded to. It's not the greatest drug in the world, but honestly, if hair loss is your major concern when using test, then you got bigger issues, okay? I mean, testosterone gives you so many advantages and so many benefits to its use. Okay, so we're 2 minutes over right now. Nelson and Brett, are you guys okay to answer? I think there's like 4 or 5 more questions. Are you guys okay to answer?
Yeah, I'm fine.
Sure, go ahead.
Okay, go ahead.
So, next question is from Tyler. Can you recommend a protocol for titration? For example, suppose blood work shows you're around 1,300. How much would you lower the administration dose, and how long would you suggest waiting to reevaluate? For discussion's sake, I'm using propionate EOD. I don't know if I pronounced that right.
Right. Testosterone or propionate every other day. Nelson, do you want to answer that before Doc does?
Yeah, I tell guys that everybody has a wall to hit. I mean, people say, well, how high is too high? It says, well, I'm not, I'm not one of those that thinks that you should be always under 1,000 nanograms per deciliter. I think it's driven not only by the way you feel, but also by what kind of side effects you may be showing up with. The number one side effect of testosterone replacement is increase in hematocrit, increase in red blood cell production. Testosterone is what we call a hemopoietic drug. It stimulates the bone marrow to produce more red blood cells. And this is great. This is a great thing, especially for people with anemia, that feel tired and all that. But there it gets to a point where the blood is so thick because there's so many red blood cells that you may have cardiovascular issues. So at higher dose, you tend to have more hematocrit issues. So you may have to, the way to manage hematocrit is to donate blood, or you cannot donate. Some people like me, my blood is a hazardous waste, so we have to get an order from a physician. It is. There's a huge list of exclusions for people that want to donate blood. But anyways, you can get an order from your doctor to go and donate or get some blood out of your system to decrease that. So you can go as high as you can if you have a good hematocrit under 52. Your estradiol is managed under 30. Doctor was saying 20 in his point of view. You're not having excessive, some people feel really hot, some people feel a little too stimulated, and they have issues with sleeping well. I sleep better when my testosterone is good. My testosterone is usually 1300. That's the number that I usually run.
My last 3 blood tests have been 1233, 1540, and 1460. And I mean, I've been not as long as you, but 14 years.
Yeah, and what happens, what we're seeing, actually, there's studies now following this, is that even guys that have increased hematocrit, and that usually happens within the first months in most people, and older or younger smokers tend to obviously have bigger issues. Then the hematocrit increases tend to level off, and your body starts readjusting. And for instance, I only had to donate twice in 24 years of testosterone. So my hematocrit has never reached 1,300 right now, more than 52 on the scale. So the answer of what is the highest testosterone, how low should I go, depends on how you feel, how much your body can withstand this certain estradiol or hematocrit, or in very rare cases, very rare a little decrease on kidney function, but not usually in guys that are working out a lot. But everything else is pretty much, even the prostate issue is not an issue anymore. It's been studied and it's proven not to be an issue. Liver function, really, injectable or gels don't cause increases in liver function. The oral, we used to have an old oral methyl testosterone that caused a lot of these problems. So some doctors don't want to see over 1,000, so that's actually a physician's imposed criteria. Some physicians, as I said, like my doctor says, well, if you feel good at 1,300, your blood work looks good, hey, more power to you. Right. So whether or not, if you're asking that question, whoever asked it, is probably because you may have been having issues with 1,300 and you want to lower your blood levels. Usually, most physicians, and Dr. Osborn can add to this, don't retest you again. You probably wait 4 to 6 weeks before they retest you to see what your blood work is. You can also use discounted labs for that. Is the testosterone panel is $50 or so, and also the way you feel. So it's the titration issue. It's personal. It's a very individual, and sometimes driven by your doctor or your insurance company.
Anything you want to add to that, Doc?
No, I could just tell you from a sort of the medical legal side of things that we have to be very, very careful as far as where we're pushing individuals' numbers. As I had said, what I do, and you've heard me talk about this before, Jay, is I typically will push my patients right to the edge as far as total testosterone is concerned, and depending upon the scales, you're talking about somewhere around 1,200 or so. Right. I tend not to allow people to go too much higher. Just again, despite them feeling really, really well, we're typically going to feel great. Okay, if we were to push our testosterone levels up to 2,000 and 3,000, probably going to be feeling even better. But that's not really a justification, for us to shoot these, levels through the roof. So I am sort of inhibited or restricted, just from the medical legal aspects of it. Where these numbers came from, where the 1,200 came from. I have absolutely no idea where they came from. We get our normal scales, and the reason why they're so huge is because what we do is we assay, adolescents, say, somebody that has testosterone levels that are supposed to be very, very high, and we find out that 95% of them, if you just use a normalization curve, 95% of them are higher, and then you have the other end of the spectrum of, the elderly individual who has testosterone levels. 95% of people are going to be, say, at 200. Okay, so somewhere between 200 and 1200 is going to be, 95% of the people are going to be sitting within there, and that's really where we come up with our scales. We don't have people running around typically, even as 18-year-olds with raging hormones, that are sitting around 2,000.
Right.
We just don't. Okay, so it's super physiologic, and we're not in the business here of enhancement. Okay, we're not doing that. We're not prescribing synthetics to make people turn them into bodybuilders. That we cannot do. What we're trying to do is restore the hormone profile of somebody who is a very, very vivacious youth. Okay, so we were assuming that their testosterone level is probably 11 or 1200, and so I aim for that. Okay, again, just from a medical legal standpoint, is there anything wrong, as you had said before, with going, to 1500 as an example? Well, there's nothing wrong with that. It's slightly super physiologic. Okay, in the context of our scale, right. Does it make you feel good or better? Probably. I think it probably makes you feel great. And again, that's all well and good. But we have to be careful, right. As far as the the medical legal aspects of it. As far as the question is concerned, and as Nelson had said, it's really a whether or not you titrate or how I titrate things. Typically, a function of serologic levels. So I take a look at their total and their free testosterone, their estradiol levels, and of course the most important thing is how they are feeling. Now, if your number is very, very high. Okay, your total and your free testosterone are through the roof, okay, for whatever reason, okay, and you're feeling lousy, okay, I can tell you for sure the answer is not to go up on the testosterone. The answer is look somewhere else. Like you said before, Nelson, sleep quality, nutrition, are you overtraining, which are huge, okay, factors, okay, and typically more so problematic than any testosterone level, because I can tell you, once you give somebody just a half a cc of cypionate a week, okay, I'm just using that as a rough, right. They're already going to feel better, okay, just from the cypionate. If they're sitting at 200, you give them a half a cc of cypionate, they're probably going to go to, say, 700, okay, they're going to already feel a zillion times better, okay. Now it's testosterone unto itself, okay, and this was stated previously, is not the end-all, be-all, okay, right. It's part of a picture. You've got to eat right. You've got to sleep. You've got to exercise. Okay, and the testosterone is just another factor. Okay, so it's not so much, Scott. Where do you titrate? How do you do that? Okay, you make sure everything is in line. Okay, everything is in line. You check the numbers. Okay, you get those numbers to optimal ranges. Okay, you push those. You push the free and the total right to the edge. This is what I do with my patients. Okay, and then you continue to optimize everything else in the picture, okay? And there are plenty of other factors, okay, which typically people don't want to control. Why? Because they take work, okay? To inject testosterone once a week is a joke, okay? But to eat right, to exercise, to make sure you get adequate sleep, to not overtrain, those are all sort of fairly, it's more rigorous to get those things. It takes a lot more work to get those things right, okay, than it does to just inject yourself.
You guys, both those questions were awesome. So Scott, for like 3 or 4 more minutes, just this is what we're going to do. You're going to ask the question. Nelson and Brett are going to answer them. They get 1 minute to answer them. Next question, go.
All right. I love that. So this question is, Nelson, what are your thoughts about metformin in the whole hormone picture? Obviously, this guy's familiar with what we talk about, Dr. Osborn, and how we're all a proponent for that. He wanted to just get your opinion on that, Nelson.
Metformin is a drug used one of the oldest drugs used in diabetes to control blood sugar, decrease the amount of insulin in your blood. Some of us have insulin resistance, and I say some of us, in my world, medications that we take cause insulin resistance, or your insulin is not really working that well, so your blood sugar starts higher, you don't have glycogen in your muscles, and your liver starts converting that sugar into triglycerides, and triglycerides is the food of fat cells. Yep. So you get fat. But anyways, metformin decreases insulin resistance and has been shown to improve blood sugar. It's becoming kind of an anti-aging drug because there's also some benefits when it comes to even survival, especially in diabetes. Yep. There's some data, especially coming from my world in HIV, where we've seen the use of metformin allowing to have people decrease fat mass, especially in their visceral area, hips of subcutaneous. So metformin when prescribed to somebody that may have insulin sensitivity, and your doctor can tell you what that means and how to test for that besides glucose, can actually help with body composition and metabolic issues. However, metformin decreases the absorption of B vitamins. It can actually decrease testosterone in itself. So that's something that needs to be looked at, and obviously you may have to supplement vitamins or testosterone when you're doing metformin. So that's my 1 minute.
That's an awesome answer. Good job. Next question for Brett.
Yep. So Brett, it's from Rick, and he kind of asked two. I'm going to wrap them into one. So he asked, should bone density scans be considered as part of a prudent TRT program every couple of years? And also, should blood tests be taken on the last day of a 1 week cycle before injecting the testosterone for the subsequent week or after 48 hours to measure peak level?
Yeah, I'll answer the first question and the second question first. The answer is I check my patients' levels on day 6 of a 7-day sort of injection schedule. I don't like seeing peak levels that are through the roof. Okay, in patients, which would be the case if they're measured 48 to 72 hours post injection. I don't like seeing that. Again. From a medical legal standpoint, I don't want numbers 2,000 and 3,000. Okay, the numbers that we're talking about, the 1,100, the 1,200. Okay, those are typically measured right on the day right before the injection at about day 6. Okay, and that's just something that's sort of standard. And this is one of the reasons why I don't. And that's sort of how our injection dosage and frequency, really the dosage, okay, is gauged. Okay, and that's again something that has just been standardized over time. Knowing the sort of the pharmacokinetics of these drugs. So I don't want to see the level is going to sort of trend upward and go up, okay, in about 48 to 72 hours. I'm talking about cypionate, okay, and then it's going to sort of, sit up there for a day or so and then start coming down very, very, very slowly, okay? So you're not going to get a trough level, okay, a lowest level when you're at day 6. This stuff sits around in your system for weeks, okay? But you're going to have sort of a nice, what we believe to be sort of a nice, not so much a steady state level, but sort of a mid-range level. Okay, and we shoot for that number to be near that high edge, okay, of the standard scale. And this is something that again just has been worked out over time, and is sort of it's just something that is standard as far as our looking. And this is one of the reasons why our assessments are, and this is one of the reasons why, I don't like patients going on. Good night, pretty girl. I don't like patients going on every other day injection schedule because their numbers become very, very erratic. Some of them come in with levels that are very, very high just because they're checking at peak time. So I really discourage people from doing that. And I just like the once-a-week injection schedule, okay, and that's it. It makes it very, very easy for me to follow. The next question is a good question about the bone density. I'm not very concerned about bone density in men, particularly men that are very, very active, because as you are well aware, both testosterone and I'm talking, Brady. Both testosterone and the strength training, which these patients are all oftentimes very, very involved with, and if not very, very much encouraged to do in the wake of our meeting, it's usually not an issue. These patients usually have very, very robust bone densities. Now, in a woman that's postmenopausal, okay, undoubtedly it's an excellent test to get, particularly as a baseline. Because these postmenopausal women are at very, very high risk for the development of osteoporosis. That said, the progesterone, the estrogen, and the testosterone, which oftentimes are being prescribed by me, bolsters the integrity of their bones. Okay, so I'm not worried about these patients losing bone mass. I'm worried about where they are. I'm talking about the postmenopausal women, where they are immediately, and then we can check later just to make sure that we're doing our jobs. Okay, but undoubtedly, okay. If they are on progesterone, estrogen, and testosterone, their bone densities and their strength training, their bone densities are going to be augmented. So testosterone hormone replacement typically only reverses bone loss, age-associated bone loss. And as I've said 1,000 times, okay, in blogs and things like that, osteopenia and osteoporosis, okay, which kills, okay, by virtue of fractures, kills thousands and thousands and thousands of people a year, okay, and costs us billions of dollars, is a preventable disease. Preventable disease. Exercise, supplementation and hormone replacement. Okay, that disease would go away, just like type 2 diabetes would essentially be eradicated. Okay, if people exercise and ate properly, osteoporosis, osteopenia would be similarly eradicated if people just paid attention.
That was the best 1-minute answer I have ever heard.
All right, last question for Nelson.
Yeah, one more question for Nelson. We're done.
Okay.
All right, what are your thoughts for sub-Q injections?
Okay, well, yeah, we discussed that a lot on excelmail.com. Yeah, I've tried all of them. I used to inject on my butt for, 15 years.
Right.
I had a problem with my hand. I had surgery, so I was left with only one hand, good hand. So I said, so I need to, obviously it's a different situation there. I started exploring sub-Q under the fat layer on your abs. There's good data that shows, it gets in the blood system, in the bloodstream. There's actually a pharmaceutical company developing a sub-Q injection of testosterone. But I have issues. I think injecting in the fat layer can also probably increase estradiol levels. It causes site reactions. I've seen some guys, hear some guys complaining that there's a spot on their abs. They're self-conscious when they're trying to have sex with somebody and they're looking at their. So there's a lot of site reactions to that. So I'm not. To be honest with you, it's an easy injection. You use an insulin syringe. I mean, it doesn't really hurt. You pinch your abs and do it. I'm more, and this is me, and this is just a method that I've developed because of the issues I have with my right hand, is that I use an insulin syringe and inject on my shoulders. Basically, it's intramuscular, very shallow, half an inch. Doesn't hurt, and it gets me away from injecting on my buttocks. So, the data is there. It shows that sub-Q actually raises blood levels of testosterone pretty effectively. Some guys love it. If you have very low fat content, it may be more of an issue. If you have fat, you have to, I think the estradiol issue may be there, and the site reactions. So I'm more of a proponent of, and this is, as I said, this is not widespread. This is something I do, and this is something I did because of necessity. I inject very painlessly 90 degrees to my shoulders in an intramuscular way, a very shallow, half an inch. And my blood levels are actually higher now with lower. I only inject 50 milligrams of testosterone twice a week.
Right.
So it's not, and I'm at 1,300. So you can actually attain good levels of testosterone without overdosing. I also use HCG too, because I do feel that it provides sexual enhancement issues and testicular size benefits.
Awesome. Guys, we've been on. Scott, thanks for staying on.
Yeah, thank you.
This was a completely awesome show for sure. There's a lot of great information. I can't wait to get you the recording, Nelson. Of course, Brett will post this all over our social media walls. The only thing I would say is I want to make this, I think, more regular. I think we can really make this show into something even better. The Q&A, we'll get more and more better Q&A. I thought that everybody did an awesome job. All I can say is thank you guys for calling up.
Yeah, well, thank you guys. And hey, all I want to say is my dad has always said this. He said there was a few perfect heads in the world and the rest have hair on them. There.
Some don't. Thanks a lot. Thanks for having me.
All right, guys. We really appreciate it. Scott.
Nelson. Looking forward to it. Looking forward to meeting all of you next month, too.
Yay!
For sure. I'll be in touch. Anything else, Scott? You good?
We're good, man. Take us out of here.
Okay, guys, we really appreciate it. We'll get everything on here, and until the next show in a couple weeks. But thanks for Nelson for coming up, and Dr. Brett, as always.
My pleasure.
Thanks, guys.
My pleasure.
You guys are awesome.